continuation of this topic, Dr. Chetan is going to tell about how to detect abnormality in corneal tomography and topography.
Thank you very much, sir. I think in my slides come on, Dr. Alisha has very nicely covered all that normal topography that we look for. As I come to my presentation, you're going to see some overlap, in fact quite a bit of overlap, because you can't talk about normal without talking about the abnormal and vice versa. But this is a little bit of a, I think, topic which is difficult to grasp at the postgraduate level, so a little bit of repetition never hurts. And I'll try to show it more with examples and with what is normal. And so what I've added on to how to detect abnormality in corneal tomography and topography is how to recognize what looks abnormal and what actually is not. Because any map that you see has some variations. No person is exactly, let's say, 5 feet 10 inches tall. Somebody would be 6'2", somebody would be 4, but all of them are within the normal range, normal physiological spectrum. So that's the way it is for the cornea, whatever the parameters we look at as well. That's important to remember. Now, what is the information that we seek from any device? We are looking at the curvature of the cornea. We want to see the thickness of the cornea, and we want to see the elevation. The concept of elevation Dr. Alisha has just introduced. Grossly, we are looking at these three things to screen a patient to see whether the patient either has a frank ectasia or has the potential to develop an ectasia in the natural course of the disease or after refractive surgery. Now, this is the map which has been shown to you. We look at the four things: the curvature, the front elevation. Is this the pointer? So the front and the back elevation and the pachymetry, and the two circles I've highlighted in this one. Which one? This one? And the two circles at the back where we look at the keratometries and the pachymetry. And this is the Bellin ambrosia, which has been explained. If time permits, I'll come back to it. Now, it's important to know that various topographic patterns have been described. There are 10 types of patterns which have been described for the spectrum of cornea, ranging from the normal to the pathologic. There are some patterns which you are very happy to see. If you see a round pattern, that is central steepening, or an oval pattern, or for example a symmetric bow tie, we are extremely happy to see these patterns. A lot of disease recognition is about pattern recognition. On the other hand, if we see patterns like an inferior steepening or an asymmetric bow tie, usually they would suggest some pathology, and we need to have our guards up. Now, this is the examples from patients. Classic, where you see the symmetric bow tie where the two lobes are equal. On the other hand, you have an asymmetric bow tie where this is not yet pathological, but the bow tie is not symmetric, both lobes are not equal. And this is a case of frank keratoconus where the upper lobe is much smaller than the lower lobe, and also it is tilted at an angle which is known as the skewed radial axis. I'll come to that if time permits. So once we look at the curvature maps, especially the axial map which is normally used for screening, what are the abnormalities we need to look for? So we are suspicious if the central K reading, which is shown by Km, I'll come to that, is if it's less than 47.2, it is normal, considered normal. Of course, I'll repeat, any parameter has to be taken in light of the other parameters. But for this parameter, if it is less than 47.2, it is normal. Between 47.2 to 48.7, you would suspect a keratoconus. The patient would be labeled as that. And more than 48.7 would be keratoconus. These are the modified Rabinowitz-McDonald indices for keratoconus. The second important is we want to look at, normally the cornea is symmetrical. The superior is a mirror image of the inferior and nasal for temporal, like that. If we see asymmetries, then that suggests pathology. And usually we know that keratoconus or any ectasia occurs inferiorly. So we look at the inferior-superior difference. If the inferior cornea is steeper than 1.4 mm on the 3 mm circle, then again it is suspicious of a pathology. On the other hand, sometimes superior ectasia can occur, but for that the limit is higher. If the superior is more than the inferior by 2.5 diopters, then we consider it to be suspicious. And corneal astigmatism more than 6 diopters on any scan again would be suspicious. So this example, the image that is being shown here, this was a patient who had actually come for refractive surgery with a high myopia. So we see that the K1, K2, Km is less than 47.2, it's 46.2, right? So this falls in the normal criteria. Astigmatism is less than 6 diopters, but the inferior cornea appears steeper. But is there a way to quantify it? One is just looking at it, and the other way is to quantify it, and that is here. You can go to this topometric map, and here on this, at the bottom we had this box which shows you the parameters of the corneal topography, and it shows you this inferior superior. It will show you inferior superior value basically refers to it's a combination of, like you have in the visual fields, the difference between the average of 5 points on the superior half and 5 points on the inferior half on the 3 millimeter circle. So an average is taken and then you subtract that. If it's less than 1.4, it's normal. Between 1.4 to 1.9 keratoconus suspect, and greater than 1.9 keratoconus. But again here important to remember, some patients may have central keratoconus. The cone is very central. There in the earlier stages of the disease you would not have that asymmetry. Right? So K readings of more than 47.2 and inferior superior asymmetry of more than 1.4 should have us looking for the other red flags. One thing to remember about topography, that's all I'll speak about topography for now, that occasionally even eyes which have a normal topography can present with appearances which are abnormal because your line of sight, the center of the pupil and the corneal apex may not coincide. For example, if the patient tilts the head or some reason, these are images taken from Dr. Bellin's book, and these are the topography of the same patient, but it looks abnormal because the line of sight did not match. But that happens occasionally. For your level, probably it would be better to remember that if you see some abnormality in the topography, one assumes it's abnormal and look for the other sides. The other thing is the pachymetry. So once we talk about the corneal thickness, I'll straight away first tell us what the red flags are. So when do we need to be suspicious? If the thinnest location is less than 470 microns, okay? If the thickness at the apex of the pachy and the thinnest location is more than 27 microns, that has been shown to have a nearly 97% chance of ectasia. So more than a 27 micron difference. Again, if the superior inferior difference is more than 30 microns, and also always look at the other eye. Both eyes are mirror images of each other, so the difference in thickness between both locations, if it's more than 30 microns, one should suspect that there may be some pathology going on. Pachymetry can be depicted in three ways. You can have the absolute values like I showed in the previous scan. It can be compared to a normative database where you have, so it will show in plus if it's thicker than the normative and minus if it's lower than that. And the other is, on the other half of the Bellin-Ambrosio map, you have the corneal thickness distribution. Corneal thickness, the way the thickness is distributed across the entire cornea. That is something which is important. And why do we need to look at the distribution pattern? Because it's been shown that the central single value is the least reliable determinant. So you may have a cornea which is 460 microns, but you don't know whether it's normal or abnormal because that determinant is not reliable as a single determinant. On the other hand, an abnormal thickness distribution is an essential criteria. So for example, in a keratoconus, you would have a thin area which suddenly moves on to a very thick area. Whereas in a normal cornea, the change in thickness from the center to the periphery would be very, very gradual. And essentially, this is all that these maps represent. These start at the thinnest point of the cornea and they are going to the periphery. So if your lines fall, this red line falls between these, either of these lines, and is following the normal curvature, it essentially shows you that your profile is normal. That's grossly how you understand it. And so there are lots of parameters which Dr. Alisha has touched upon a little. I won't go into all of them, but there are some parameters here which we need to know. One is there's something known as a PPI index, pachymetric progression index. That again is how is the pachymetry progressing from the center to the periphery. And there is another thing which is known as the ART max, here it's shown, Ambrosio relational thickness. That is a ratio of the PPI to the thinnest point of the cornea, right? So just we need to remember some normative data. Most normal eyes would have a PPI of less than 1.2, but there is some overlap between normal and keratoconic eyes. So 7% of normal eyes may have a PPI greater than 1.2, and 10% of cases, even with keratoconus, would have a normal pachymetric progression in the early stages of the disease, right? So don't confuse this, but just this is again all to remind you that you look for multiple factors before going into any diagnosis. And the last thing which we look at is elevation, which Dr. Alisha touched upon, which we compare to a reference surface. So whatever is above that or below that is abnormal. Reference surface is an artificial surface which the software fits onto the data that you have gotten for the cornea. And normally it is the sphere which is used as a screening tool. But if you want to go into finer detail, there are options on the machine of looking at a toric ellipsoid, because the cornea is actually not a sphere, it's a toric. So again, what's abnormal? This has been said by Dr. Alisha. There may be some values different. You may find values in these slides different, because because they are for different reference surfaces. Normally anything more than 12 or more than 15 on the anterior and posterior. And also, apart from the values, you need to look at these patterns. So if you see an island pattern or if you see a tongue-shaped pattern, that is something which suggests pathology. On the other hand, this is a cornea with a regular with the rule astigmatism and you see a nice hourglass pattern. Apart from the values you look at, please look at the pattern that you see. And this has again been highlighted, the Bellin-Ambrosio enhanced ectasia detection map. And for this patient you can see the posterior elevation is around 10, which you could easily miss. But on the Bellin-Ambrosio map, it shows up much better than you do. So never comment on whether a patient is normal or abnormal without looking at the Bellin-Ambrosio map as well as looking at these 5 parameters. So these 5 parameters are various indices like deviation from front elevation, back elevation, which have been compared to a normal database and then said to be within 1 or 2 standard deviations of normal. And the combination of these 5 factors is given as the overall D value. So if this overall D value is yellow or red, especially if it's red, that suggests that it's more than 2 standard deviations away from normal and you need to be careful, right? And the last thing which I was coming to, that minimum pachymetry, because so this is the part where you see how to recognize what is abnormal, looks abnormal but is actually normal. It's been seen that 0.1% of patients with normal corneas can have a pachymetry of 442. It's a very, very small number, but it can be there. Similarly, around 0.1% of patients can have corneas of around 48 diopters. And I'll end it up with this example. So this is a 23-year-old female who wants refractive surgery. Her KM is 48.7. So remember we had that value of 48.7. Her pachymetry is 457. I had told you less than 470 is suspicious. And she has an astigmatism. But you see that there is no elevation. So ultimately it is elevation that we rely on. The Bellin-Ambrosio maps, this enhanced ectasia detection is completely normal. There is no abnormality because there is no irregularity on the surface. These parameters are abnormal because these parameters ultimately reflect some limits of numbers. If those limits are beyond those numbers, they will be abnormal. So this is certainly not a case who we want to take up for a cornea-based refractive surgery, but this is also not a case who has ectasia. The best you can do is tell these people that don't get a corneal-based refractive surgery done, and we want to keep you under regular follow-up. But in your mind, you know, and you can reassure the patient that this patient does not have keratoconus. So no abnormal elevation, not all steep and thin and steep corneas are ectatic, and pattern recognition for ectasia is an important assignment. So I think I'll end there. Thank you very much. And before I end, I would also like to invite you. We have a CME on this Friday, 7th of May at Shivalik View at 7 p.m. We have these stalwarts from retina and the field of anterior segment from Shankar Netralaj and Madurai, RP Center and LVPI Bhubaneswar who will be giving talks. And I would like to invite you all to be there at 7:15 p.m. onwards on Friday.